Respected seniors, my dear colleagues, at the outset, I thank the Veterans Memorial Medical Center, Department of Surgery, Section of Urology for holding this Urology Week and inviting me to talk on thulium fiber laser enucleation of the prostate from the section course director, Paul Espina, who is conducting the 12th VMMC Urology Postgraduate Course, Veteran Memorial Medical Center. And I also thank Eli Paulino Madrona, who is Chief Section of Urology, Department of Surgery, Veterans Memorial Medical Center. As you all know, thulium fiber laser has come way ahead in the field of enucleation of the prostate, as well as the stone management and en bloc resection of the bladder tumor. So I am myself Dr. Chandra Mohan from Hyderabad, southern part of India, Managing Director, Preeti Urology and Kidney Hospitals, and also founder of Pure Urology Program, which is Facebook online focused on surgical techniques. To coming to the topic, the thulium fiber laser enucleation of the prostate, the future of enucleation, to introduce the thulium YAG is not equal to thulium fiber laser. So we have to remember that both are different. Thulium fiber laser is not YAG laser. In fact, this is pumped by diode laser, not YAG laser, electronically modified to alter temporal beam profile. This thulium doped 10 to 20 micron core diameter, 10 to 30 long silica fiber. These diode laser passes the light, and with internal reflection, it will produce a beam which is continuous laser. That is its characteristic. Now, TFL properties, as you all know, already many of you might have seen these slides. The tissue ablation threshold, it has very water high absorption. Naturally, in urology, prostate and stone, you will be working in the water. The laser which is absorbed by the water maximum will have maximum efficiency. It is more than 2 times of that YAG laser, 4 times of that of the holmium YAG laser. So this translates into lower tissue ablation threshold and faster enucleation. It cuts by absorbing through the water and producing the heat very fast. The pulse profile, if you see YAG laser, whatever the pulse that is produced, it has up and downs in peak power, whereas in TFL, peak power is constant and low. Peak power is the power used during the pulse average. It is almost flat. And second thing is, it has long pulse width, uncomparable to holmium laser. Holmium has maximum 1300, whereas thulium fiber laser 12,000 microseconds, 12,000. That means long time it will stay with the tissue. Now, laser beam profile also, if you see, it has a constant uniform laser profile beam. The precise cutting is because of its depth is very, very less. Even sometimes pioneers like Dimitri Enkiw says that ureter, if it is touched, it is only 0.15 mm. It will not be deep enough to cause fibrosis. It is 2 times less than thulium YAG laser and 4 times less than holmium YAG laser as far as the depth penetration is concerned. However, it is coagulative laser also, so the bleeding will be very, very less. Now, the literature review, we say that many in urology article, Dimitri Enkiw says that it is associated with simple learning curve, achieving proficiency in as few as 8 to 16 procedures. Naturally, holmium enucleation of the prostate is technically demanding. It took 20 to 30 years for still learning curve is so steep. Sometimes you perforate the capsule. If you miss the plane, it is difficult. But in thulium fiber laser, you can get back to the plane easily, and junior need not be worried so much about the loss of the plane and incompletion of the procedure. You can do a little bit part also and then re-come back to the enucleation, whereas HOLEP takes 50 to 60 procedures. Faster enucleation rates is literature p-value is significant in this article, again written by Dimitri NQ in a randomized controlled trial published in 2018 Urology, one of the very early articles, is superior to HOLEP. They say that it is 1 gram versus 0.8 grams versus 0.7, 1 gram being the thulium fiber laser. In comparison with HOLEP and MEP, ThuFLEP was slightly superior with 25% and 42% faster enucleation rates respectively. However, there is no statistical difference. Impact on erectile function, and this is research article, most of the articles by Dimitri NQ because he is the pioneer. He says that IIEF 5 score shown significant increase of 0.72 in ThuFLEP group comparing to 0.24 in TURP. TURP definitely causes some amount of erectile dysfunction, but lasers appear to be less because the heat transferred to the prostatic tissue is less. So to prevent the erectile dysfunction, it takes 6 months for the TURP, whereas in thulium fiber laser enucleation, it is very less. Environmental friendly, there is no doubt because it consumes very less energy, and it is wall plug efficiency is 12%. You can directly put, classically they say that you put to the hair dryer and use this laser. Literally no noise in the OT. To be honest, the 100 watts or 120 watts holmium laser produces a lot of noise because of the fans present, because of the cooling effect, because of the heating of the multiple the laser producing machines inside 3 to 4 will be there. They produce a lot of heat, and that may cause noise hazard also. The instruments are standard like in any enucleation. Only working element will be having a laser fiber channel, which you are seeing in this picture, and you have 200 micron fiber, 400 micron fiber, 600 micron fiber. Naturally, 600 micron fiber is used more commonly in enucleation. 400 also used for fine cutting. 200 is not used for enucleation. It is only for the stone lithotripsy. Now, if you see here, I am sharing the outer sheath 26, inner sheath 24. In future, these sizes may come down. This is the classical working element of the TURP. This will not be useful this is the TURP, the passive movement of the electrode, and this will not be useful for the enucleation. And this may be used in the coagulation at the end if required. Now, the same, the laser resectoscope is like this, where you have only one channel at the side. This is from the coral starch, no conflicts of interest. It works same like that. It is a rubber cap to prevent the water leakage, and it will go into the same 24 inner sheath of the coral starch again. So if you buy this working element with laser fiber, you can do enucleation of the prostate. And the telescope is same. The 2.4 size telescope is used, and this movement of the laser fiber channel will help in enucleation of the prostate. Exactly, you are showing all the instruments here. This is the visual operator first to introduce into the urethra. This is very important because it will prevent injury. Like most of us are using this under vision, you can pass this, and same thing can be used for laser fiber also, which is made in India. That means the visual operator which is introduced also has a small channel, but only thing is that front and back movements of the working element will not be there. That is a disadvantage of this visual operator method. And this is the visual operator with a channel for the laser. Slim and ultra slim 18.5 is also available, 26.5 is also available. Smaller the better, because for laser mechanical pressure is not used, it is used less. So nephroscope also can be used 15 French for enucleation, but outflow inflow characteristics will be better with the 24 by 22 or 26 by 24. Important slide is settings. If you see the thulium fiber laser has wide variety of settings, so many people suggest so many settings, but the standard recommended by the pioneers like Dimitri Enkiv or the Scafone, these people recommend 1 joule and 30 Hz short pulse when you are a beginner. You can use 1.5 and 40 for the experienced person. Hemostasis is low energy, high frequency, 0.1 joules and 300 Hz long pulse. Long pulse produces coagulation. You have 2 pedals, 1 pedal for the incision, another pedal for the coagulation. Now I am demonstrating the video. See how many stones are there here, secondary stones. All the stones can be removed. Fortunately, they are very small. All have come out. Very large prostate gland. 1 stone was big. See how fast thulium fiber laser can do the breaking of the stone. And now see the hungry, large, around 70 to 80 grams prostate, which is vascular. Now see, I am using in the paraveru groove, first mucosa will be incised, and a bit of the mechanical pressure is used in thulium fiber laser. Is the advantage or disadvantage? We cannot say. This is inverted lambda incision to be given precisely in that groove and develop enough deep so that, see how the cutting property of the laser is there. See this getting separated by itself with little mechanical pressure. I don't deny that. See, this is the mechanical pressure. This is the mechanical rotation, but this rotation is very, very minimal. Lot of the homium laser surgeons will say, see, the sphincter and the gap will be there. They say that this is not required even with the thulium fiber laser. See, this is the incision in the mucosa, leaving little bit of the mucosa at the paraveru region, and now from the paraveru region slowly release at the capsule. Only important thing is that initially go deep enough that you don't go through the gland. Thulium fiber laser, if you throw the gland also, it will cut. You can see now both the lobes are getting separated from the capsule. See, even if you don't touch, it will cut. This is with 1.5 joules and 30 Hz. Only thing is that you need to understand the plane. If the plane is not formed, you do little bit of the lateral rotation. See, this is uniting. This is the technically demanding part. Anteriorly, at a 12 o'clock position, you have to carefully unite both lobes. This is the junction. You have to release with a little bit of cuff leaving so that it will not put traction on the sphincter. These are all the ABCD of enucleation everybody teaches, whether it is homium laser. Now completely I am in the retropubic plane. Once you come into this plane, you will be so nicely enucleating the gland. So this is the mucosa which is not at all damaged, and this is the sphincter, and next to sphincter you have left the mucosa and already you have enucleated the sphincteric region gland. Now you are safe to do faster. Once you release all around retropubic region is very safe. Now we are doing on the right side, the left side of the patient. If you are not following closely, understanding the surgery will become difficult, but you can see the laser fiber separated a little bit with the, this is at the 6 o'clock position, total 180 degrees, the camera is rotated and laser fiber is always touching the 12 o'clock position of the camera. So you can see, appreciate here how they are getting separated without any bleeding. And coagulation effect with the thulium fiber laser is very good. Even a large bleeder will immediately be coagulated. On either side you do it, don't try to do on only one side. Traction will be there on the capsule as well as the prostate. It becomes difficult. Now at the bladder neck region, we are slowly incising. Wherever you touch, it incises very well. If you can appreciate, not much bleeding in any point of this vascular gland. So if you keep on pushing, and then see, this is almost finished, the left side of the lobe, and we are finishing on the right side of the patient now. En bloc resection is possible. I like en bloc resection. I'm in the learning phase. I might have done more than 100 cases now. Still, to understand the laser settings, because of the wide variety of these orifices, already the gland is pushed inside. Now morcellator can come. Any morcellator you can use. I use the Quanta morcellator, which is reasonably good. Pirano is also good. Only morcellator should be used in a full bladder. These are all primary principles, and one should check and keep a hand on the bladder, and you should have two inputs. We do morcellation. You can appreciate the mucosa intact at the bladder neck region without any tearing effect, so that the continence can be maintained, and morcellator tip is faced above here. Now, these are the two videos where 130 dam prostate in the beginning and at the end, we are showing. See, the prostate is very, very big vascular here, 130 grams. In enucleation, advantage is whatever the gland size, whether you do trilobar or two-lobar technique, it will be see the vessels around the bladder neck region and the orifices. If you can see the orifices before the surgery, it gives slightly better confidence. Large median lobe is present, and the trabeculated bladder and hypervascular bladder mucosa and hypervascular prostatic mucosa also. In TURP, a lot of bleeding will happen, and this is the laser fiber which comes. The steps are same, and now I am showing at the end of the surgery how it looks like. Same gland. You can appreciate the wide opening with normal intact mucosa. You don't mind leaving small amount of tissue which will not cause resistance for the urine. It's better to leave in the beginning period than produce incontinence. One of the common complications of this surgery is not bleeding, but the incontinence. Incontinence is morbid procedure. You can appreciate the capsule all around with a little bit of coagulation effect. See, like this, you can coagulate. If you touch, it coagulates. And all around there is absolutely no bleeding, and intact the sphincter is present in this case in this large gland. So even 130 grams prostate also can be done. Time taken with approximately 1.5 hours to 2 hours. The morcellation time is very less. So this is the capsule. This is the wide opening, and this is the gland which is protruding into the bladder. So you can appreciate some amount of coagulation can be done. These are the ureteric orifices. This is the gland which is pushed into the bladder. So our experience of en bloc resection is we have done around 50 cases in this comparative study. Our prostate volume is 92 grams, IPSS score is 20, surgery time is average. We are taking slightly more time than others because we are slightly slow. Enucleation time is 83 minutes, morcellation time is very less. Somehow we adopted with morcellator very well. It's around 10 to 15 minutes. Removed tissue is around 60 to 70 grams. Enucleation rate efficacy is 0.69 grams per minute. Catheterization time is generally 2 days or 1 day. Incontinence is 10% at 1 month and only 2% at 3 months. Complication rates are 18% in other way around. So enucleation is enucleation. Enucleation is enucleation. Thomas Herman has said that it is not equipment or laser that is responsible for efficacy of the enucleation of the prostate, but the enucleation technique whereby complete removal of obstructive adenoma is achieved. So don't get carried away with the holmium laser or thulium fiber laser. Learn the basic principles of the verumentonum, paraveru region, capsule. If you have difficulty in size 2 areas, do trilobar technique, do bilobar technique. If it is a small gland, do monolobar technique, no problem. Technique of lobes is not the criteria. Maintaining the capsule, not injuring the sphincter, not putting stretch on the sphincter, not using the laser around the sphincter are the very, very important points. With this, I once again thank the organizing committee for giving this topic to me. try till you succeed. Don't give up. All these procedures are well established in the world. We are not doing new. We are just following the seniors. Mistakes are proof that you are trying. Initially, incontinence will be there. Don't worry about it. Go more proximal, leave some amount of adenoma around the veru. Still, you can get plain with the thulium fiber laser. So the future will be competition between 60 watts thulium fiber laser and 120 watts ohmium laser. Maybe we never know. The thulium YAG laser also may come back along with the lithotripsy. Thank you very much for this opportunity.